Hello, it's my distinct pleasure to introduce Dr. Laura Mosqueda, who is the Dean of the Keck School of Medicine at USC. Her areas of focus at the school include groundbreaking research, biomedical education, and social justice. She's internationally known for her research on the causes and consequences of elder abuse and as a practicing family physician. So over the last year, I've had the opportunity to get to know Dr. Mosqueda in my role as Dean at Marshall, and I can tell you that she's not only an amazing scholar and administrator, but also a wonderful person. We can only imagine how hard her job has been over the last couple of months trying to manage Keck during the COVID crisis. So I'm incredibly grateful that she offered to take 45 minutes out of her hectic schedule today to come and talk to us. I don't want to take up any more of her time, so Laura, the screen's all yours.
Great. Thank you so much, Gareth and Patrick. It's such a pleasure to have a relationship with you and with Marshall. And one of the kind of crazy benefits coming out of COVID-19 is the deepening of relationships. I think all of us are experiencing across the schools here at USC. So it's a real pleasure. And I will say, Marshall, I've been doing this for a number of other schools here at SC, and you definitely have submitted the most questions. So if there's a prize that goes out later, we'll make sure it goes to your school. Well, I have been doing these community corners, and really what I started doing was just outreach literally to our community here at the Health Sciences campus here in East Los Angeles. So we had been doing community corners for faith-based groups and senior centers and business leaders, et cetera. And then we went, hey, we have our own community here in terms of our sister schools at USC. And so I hope you find this helpful. So based on the large volume of questions you sent in, I really have tried to focus a lot of my slides. Let's see if we can advance it. Oops, can we go back one? Thank you. Focus my slides, particularly on testing, because that's so many of the questions that came in. And I'm going to do a practice run right now because I just got me a laser pointer to see if it works. Let's see. There we go. I promise not to make you dizzy. So we'll be talking a little bit about the course of the illness, a few points of information regarding numbers, more information on testing, and then we'll talk a little bit about prevention and treatment. I'll probably blah, blah, blah for about 15 to 20 minutes, so that we'll have plenty of time for Q&A afterwards. All right, well, I think as many of you know, we have a large number of people who actually have COVID-19 virus, but are completely asymptomatic. So we call these people asymptomatic carriers, meaning that they actually have the virus, they're shedding the virus, but they have no symptoms from it. And some people have symptoms that are so mild that they didn't even realize it until later they say, you know what, I had a sore throat last week that was just a little naggy, but nothing ever came of it. And they didn't even occur to them that it might be COVID-19. And then we have a number of people who have symptoms. And those symptoms typically are sore throat, muscle aches that we call myalgias, so muscle aches and pains, you feel pretty miserable, a lot of fatigue, and fever, particularly nighttime fever, and a cough. So those are the most typical symptoms that people have. And then, of course, some people become much more severely ill and actually need to be hospitalized. These people might need respiratory support in the form of oxygen, medications. They might need intravenous fluids. And of course, as you've all been hearing about, we have people who are dying as a result of COVID-19. And certainly as a geriatrician, this has been very high on my radar. Many of the deaths related to COVID-19 in the past week or so in Los Angeles County, meaning in excess of 40%, have related to people who live in nursing homes or other facilities. Well, pardon this busy slide, but I'm setting us up for when we're about to talk about testing, where so many of the questions came in. But I thought I would just tell you a little bit about how this little bugger COVID-19 works. And so if you have really tiny screens, I'm sorry, but maybe you'll want to see one of our ophthalmologists when all of this is over. What we have here is the coronavirus starts on the outside, and then it makes its way into our bodies. And when it does, it goes to a cell, and what this kind of beigey area is here is the inside of a cell. So the virus goes and it locks onto a receptor. You'll see it called ACE2 receptor. And once it hooks onto that receptor, it actually is able to then enter our cell. Because we have so many ACE2 receptors in our respiratory tracts, this is why it primarily is affecting our respiratory tract, because that's where we have a lot of these receptors, and that's how the virus gets into our cells. Once it gets into our cells, it kind of takes over the cell and becomes a little virus manufacturing machine. And so it takes over the cell, it creates more virus, and then it spits the virus back out to infect more cells. So you now have this manufacturing plant making viruses. The viruses get spit out, and if our immune system is working well, it then is picked up by these things called APCs. These are, well, let's not worry about all the terminology. Let's just call them APCs for now. And those guys then, those are our own cells, say, okay, we have an invader, we're gonna pick it up, and it's going to now present this invader to what are called T helper cells. Sorry, I'm having trouble with the pointer here. There we go, the T helper cells. And when the T helper cells get involved, they then invoke the help of two other kinds of cells. One are called cytotoxic T cells, which actually destroy the infected cells, but the other are called B cells. And these are important because we're going to talk about them later, and those are the cells that make antibodies. When we talk about antibody testing, this is where it's coming from. So hopefully this makes sense. And this is kind of what happens inside our bodies when COVID-19 invades. All right. So let me move on now and talk about what happens to us. We'll zoom out from the cellular level to the person level. And what happens is we have this time of susceptibility, which unless you've already had COVID-19, we probably all are susceptible to getting it. And then we have a particular point in time when we're exposed. And once we're exposed, this little guy can incubate anywhere from 2 to 12 days. So you might have an asymptomatic phase in which you're contagious, but not even be aware of it. So you might be exposed and you might be contagious, but for the first few days before symptoms begin, you have the virus present, you're actually infectious to other people, and you don't even know it. You may continue to have no symptoms at all, or you may have the onset of symptoms. And once the symptoms begin, they can last anywhere, typically on the order of 10 days or so, but it can even be up to 30 days. And you remain contagious while you're having these symptoms, you remain infectious. And once the symptoms are over, we think it takes about 72 hours to no longer be contagious. So once you no longer have that fever in particular, and you're not taking acetaminophen, also known as Tylenol, to reduce the fever, you really don't have a fever anymore. We want you to wait 72 hours to know that you're in the clear and no longer contagious or infectious to other people. And the part of the reason I show this is, we'll use it later when we talk about testing. Part of the reason I show it also is it might help us be more understanding of why we're waiting and waiting and waiting, why we're saying you have to quarantine for 2 weeks if you've been exposed, why we're saying we're not out of the woods yet just when we begin to see things decrease. Because by the time we don't start acting well, as we saw on the Orange County beaches last weekend, until the time we see the results, it's 2 to 3 weeks. And hopefully this little graph will explain why it takes so long. It would make it so much easier if, hey, as soon as you get the virus, you get sick, and you're sick for a few days, and then we're over with, and you're no longer contagious. But unfortunately, that's not the pattern of this little bugger. It takes much longer period of time, and that's why we need to really maintain things like physical distancing for such a long time, hand washing, mask wearing, and all that. All right, well, just a few numbers. In Los Angeles County, as of 2 days ago, we were seeing the number of cases. These are the number of people who test positive for COVID-19 and their breakout in terms of percentages. You'll notice that in the 18 to 40 age range, it's about a third of people. But what you'll notice, for example, in this graph, is that those people 18 to 40 are in that yellow line. Even though this age group represents about a third of the people who get COVID-19, it's really the people over the age of 65. And if I broke it out, people over the age of 85 who are getting severely ill and actually need to be hospitalized. And it turns out it isn't just about chronologic age, it's also about physiologic age. And so if you're a 65-year-old person who has diabetes, heart failure, maybe a history of a stroke, you may be more susceptible than an 80-year-old who's in great health and doing really well. And that's what I mean in terms of physiologic and chronologic age. So what we're finding amazingly is in children, people under the age of 18 in particular, don't seem to be seeing a lot of problems with COVID-19. I'm on regular phone calls with my colleagues at Children's Hospital Los Angeles. They're not seeing kids, even kids who have cancer, even kids who have heart disease, they're not seeing kids who are coming in with symptoms of COVID-19. Of course, there are exceptions, but I'm just sort of giving you the general rules that we're seeing here. All right, let's go to what seems to be Marshall's favorite topic, which is testing, because we had so many questions come in about testing, and I'll do my best to take us through this. When we talk about testing, we need to be aware that there are two types of testing that we're talking about. One is diagnostic testing, and the other is serologic testing. Diagnostic testing is the type of testing that says, do I have this virus right now? So presence or absence of virus, and we use testing that's called PCR in order to tell. We'll talk more about that in a second. The serologic testing says, have I had exposure to this virus? And that's the antibody testing. And we'll talk more about that in a minute as well. So when we're talking about the diagnostic testing, presence or absence of the virus, we're looking here. So we want to see whether or not we find virus present in your body. So that's what the diagnostic testing is looking at. Whereas the serologic testing is looking for presence of antibody. So now you've had the virus, it's been presented to your T helper cells. Your T helper cells are trying to get it killed off by our cytotoxic T cells, and it's been presented to your B cells that are producing hopefully lots of antibody to kill this guy off. And that's what the serologic testing is going to tell us about. Of course, it's more complicated than this, and we'll go into a little bit of the complication in just a minute, but hopefully this relates back to that cartoon graph we saw earlier and makes a little more sense in terms of the testing now. All right, so diagnostic testing, that's the PCR or RT-PCR type of testing. Is this little bugger present in my body right now? And typically what we're using right now are either nasal swabs that go way to the back of the throat, or we're also doing swabs just in the mouth. And pretty soon we're hoping that we're going to show that there's good testing that can be done just using spit. So saliva, which is even easier, so nobody's sticking a tube up your nose or asking you to swab all over your mouth, but actually if you can just produce some saliva into a cup. And what we're looking at then is we're taking it back to the laboratory and we're using this PCR testing, and we're seeing, do you have any evidence of the virus right now? As opposed to the serologic testing, which is looking for presence of antibodies. And the other term for antibodies are immunoglobulins, which is why you'll hear about IgM and IgG, because the IG stands for immunoglobulins, and it's a lot easier to say. So the antibodies are the proteins that are made in our immune system in response to the infection. So what you'll see in this little graphic is the green guy in the middle is the COVID-19 virus, which is also called an antigen. So the virus or the bacteria that enters our body is called an antigen. And then what we produce in response to it to try to kill it off is the antibody. So I'm going to talk just in the next slide. Don't be afraid of my next slide here, but here we go. Woo, okay, lots of curves. Let's go through it one by one. What I want to make sense of here are the different kinds of antibody testing that you're going to hear about. So bear with me here, and let's just first focus here. Pardon me with the clumsiness on the pointer, but this is the curve that shows IgM, and I'm pointing out the IgM because that is the immunoglobulin or the antibody that tends to come up early. You'll notice that you have onset of symptoms here, and the first antibody that starts to come up is the IgM. It becomes detectable fairly quickly after onset of symptoms. But there's another antibody called IgG that tends to start showing up somewhere about 2 weeks after your symptoms have started. And that's the one that confers longer term immunity. So you'll look at the curve on the IgG antibody, that brown colored curve, and you'll see that that's the one that confers longer term immunity. We don't know though how long term the immunity is and how good it is. But when we're doing the antibody testing right now, it's tending to look at both the presence of IgG and the presence of IgM. And again, the IgG is the antibody that tends to confer the longer term immunity, but we just don't know how good it is. And this, I hope I'm not making it too confusing, but I want you to enter my world of confusion for just a minute so that you can understand why we're so hesitant to say, hey, antibody testing is the be all and end all that'll make it safe for us to get back to life as usual. And I'm sure there'll be some questions at the end, and I'm happy to take them. All right, so another bit of a complicated graph or chart anyway. And again, I just want to make a few points here, which is it isn't a one size fits all thing. We're trying to triangulate on the COVID-19 virus in order to understand it better and in order to understand what is going on with people. So it may be that at certain phases we're looking at the PCR test and then we're doing antibody testing. We know that really early on, it's the PCR saying, yes, I have the virus right now that's likely to be present. And as that wanes, then we're going to see a rise in IgM and then a rise in IgG. And so these things kind of come and go at different phases, and then there's times when they overlap as well. And they give us different kinds of information, which is why all of this testing can be helpful in informing our decision making. All right, well, with that said, I actually am, I think, well, let's stick with this for a second. PCR testing for students and faculty. So this is, hey, I think I'm having some symptoms that might be indicative of COVID-19. We're going to ask you to either make a telehealth appointment or just a plain old phone appointment with your healthcare provider. And we have, if you're here at Keck, either as a student or you have the Keck Health Plan, we've got 24/7 availability to talk to somebody, and then we could guide you to where to go to get testing done. And that testing will help us will be the PCR testing to help us tell whether or not we think you have COVID-19 virus present. Gonna go back and just talk for a minute about the antibody testing because the antibody testing is the kind of thing that we can do later on to say, have you been exposed to COVID-19? And I want to spend a minute, I'm going to see if I can go back on my slides. Pardon me, I hope I don't make you dizzy. To talk about this last bullet point here, which is what does a positive or a negative test mean with the antibody? So what we know is that a lot of the tests that are out there right now aren't very good. But we're getting better and better antibody testing available. So there's two issues of concern. One is, what is the sensitivity and specificity of that particular antibody test? And the other important issue is, what is the prevalence in the community of being positive? And you get to a little bit to a chicken and an egg phenomenon here, because the only way to know is to do the testing. But if the testing isn't very good, we don't have good answers on how prevalent it is. So at some point, you just got to dive in and do some testing and start to make some educated guesses with a lot of caveats along with it. So a positive test, right now, if it's sort of if we have a 95% specificity, we know that there still is a risk that if it says you're positive, that you aren't really positive, with the specificity and sensitivity taken into account, particularly if there's a low prevalence in the community. So we want to be careful that even if you test positive, it doesn't mean that you definitely had the virus, but it means there's a good chance you did. And it doesn't mean you're immune from getting the virus again, because it turns out that it isn't just whether or not you have IgG, but some IgG is better than others. All IgG is not created equal. And there's different titers of IgG. So some people have a lot more in their bodies and might be even more protected than others. So the jury's still out on both the quantity and the quality of the IgG. But if you do turn out to be positive, it means there's at least a reasonable chance that you were exposed and have some degree of immunity. And again, same caveats go with a negative test. Even if you test negative, it still is possible that you actually were exposed and that it's a false negative test. So right now, I would say that the antibody testing is good for us to know what's happening at a population level, but it's not yet good enough for an individual to be able to make good informed decisions for themselves. All right, I'm going to skip ahead now, so pardon me. And we talked about this, about how you can get testing if you're worried that you have the virus. This is the PCR testing and not the antibody testing. So let's talk for a minute about prevention and treatment. I'm just in the home stretch here. And it's really important, as I showed from that graph that shows how long it takes for the virus to sort of make its way through an individual and through our society, that the physical distancing is still really important. And you'll notice that I have a strong aversion to the term social distancing. It's physical distancing, spatial distancing that we want people to do. Hand hygiene, really important. Wearing a mask so that you're not coughing on somebody. You may be one of those asymptomatic carriers, really important. There are over 90 vaccines in development, and I think there's a strong chance that we'll have a vaccine up in 12 to 15 months. Again, some vaccines are fantastic and confer great immunity. Some vaccines confer good immunity. We don't know how it's going to play out with COVID-19. Other important thing, lots of treatments in the pipeline. We're doing a lot of clinical trials here at Keck. And the treatments range from everything to how do you actually look at stopping the virus to how do you provide better treatment for people who are quite ill. So a lot of different ways, as you can imagine, of attacking the virus and helping people get better more quickly and more safely. So what can we do to help mitigate this situation? Please, even if you're one of the people, you're 20 years old, you're feeling great, worst thing that's probably going to happen to you is a fever for a few days. I still need you to help protect the old people that I take care of, people who have chronic medical conditions, people who are getting treatment for cancer and immunocompromised. This really is something where we as a society can truly help each other. And it really does take self-discipline, and it's no fun to be staying at home all the time when the weather is gorgeous, but it still is so, so important to do on behalf of the vulnerable members of our society. What can you do for yourself? Give your brain a holiday from coronavirus. You don't need to be listening to the news 24/7. You don't even need to be listening to the news for 3 hours a day. You just get to a point where you're not going to learn that much more, and it just creates upset and anxiety. It's okay to wallow, but give it a timed wallow. After 15 or 20 minutes, get up and listen to some music or phone a friend or do something enjoyable. For people who really are having trouble getting out of the wallow, you find yourself maybe feeling anxious or really down in the dumps, and it's more than you really want to bear, call us. We've got great mental health professionals available. We want to help, and we're here. We're here for you. Be kind to yourself, be kind to other people. It turns out that being kind to other people helps strengthen your immune system. So, hey, go for it. Being kind to other people will help you fight off the virus. So, bonus there, okay? Keep safe. Don't be reckless. We all really need to be helping each other these days. Stay physically distant, stay socially connected, reach out to everybody so that we can help all of our colleagues in this really crazy time. So hopefully I didn't go too long here. I guess I did a little bit, I'm sorry, but with the questions you sent in, hopefully I've handled a number of them. But let me turn it back over to Gareth and Patrick for some Q&A now.
Well, thank you, Dr. Mosqueda, for that very illuminating presentation. I've certainly learned a lot in the last 20 minutes. As you mentioned, we have a number of questions that came in ahead of time, so I'll get straight to the point and pick up on some of those that you didn't actually address. A common theme running through people's questions seems to be our life at USC and when we'll be able to return safely to on-campus life. Do you have any thoughts on that?
I do have a lot of thoughts on it. I have to say one thing I really appreciated about our leadership, president and provost, is how to make sure we get back not just as quickly as possible, but as safely as possible. So I think that it's going to look, we're probably going to end up with a phased approach. We're probably going to end up with a hybrid kind of arrangements. We know we can't have classrooms where students are right next to each other anymore, that we're going to have to maintain 6-foot distance between people, masks, good hand hygiene. All that is going to become just a normal, it's going to become our new normal way of being. It's going to be everything from classrooms to cafeterias to how we sit together and keep more spaced apart. We're going to have to make sure that we're in line with city ordinances and with what the governor is saying. And it wouldn't surprise me if we're going to go through waves where we find that, oh, maybe it's popped up a little bit here. We find a hot spot, really are able to zero in on that hotspot and do some quarantining over there while the rest of the campus remains open. I think we're really fortunate that in Sarah Van Orman, who is the medical director for student health, she has a really strong public health background and is helping us understand what reopening will look like so that we can do it again as quickly as possible, but as safely as possible as well. The other thing we're really recognizing is that even if it seems okay to come back into the office, or even if it seems like, hey, you're somebody who we think can work at home, we need to take individual people's circumstances into account. You may have a health problem that makes it scarier or riskier for you to come in. You may be in a home situation that makes it more important for you to get out of the house and get back in earlier. And we're really trying to think through ways to come up with rules and guidelines, but also understand that we have to really care about each person as an individual and make sure it's something that fits your needs to the very best of our ability as well.
Thank you for that answer. And on a somewhat related note, what do you see as the likelihood of there being a COVID-19 resurgence in the fall?
Yeah, well, based on what articles I'm reading, there's a better chance of it happening than not, and so we'll all really have to be ready to see if this comes back. But the basic scientists, the virologists, generally are thinking that it is likely to come back in the fall or winter months.
Okay.
But I would say the good side of this is we're going to have better testing capabilities. We're going to be more on top of it. We're going to know the drill. It won't be quite as scary because I think we'll be on top of it so much more quickly and so much more intelligently.
Great, thank you. And on a somewhat related note again, when we return to start returning to this kind of quasi-normality, what will it take? What precautions should be taken when people need to start traveling internationally, start flying?
Yeah, a lot of us are asking that question. So right now, I don't think it's smart to travel unless you really have to. And so, for example, among my patients who might want to travel, we're just having conversations about their very individual circumstances. One example, I was talking to somebody who is in her 70s. She has a mother who's well into her 90s who lives several states away. And her mother is dying. And it's very important to her and her mother for them to be together. So we're going to try and work out the least risky way for that to happen. As opposed to somebody who just wants to travel to visit a friend, where I'm going, not so much. This isn't the right time to be doing that. So that's why I don't want to have a one size fits all answer. I think that once we do look at things like international travel, we're really going to have to be circumspect about where it is you're going. What are the circumstances over there? Is it possible that when you're ready to come home, you're going to have to go through a 14-day quarantine? And if you have good confidence that isn't the case, or if you have a circumstance where it can be, when you're traveling, to be really careful with masks, hand hygiene, being around other people, maintaining that physical distance, those sorts of things.
Thank you. And returning to the present, a few people have asked about what precautions we need to take when going to the grocery store or having groceries delivered with respect to preparing those groceries and bringing them into the house.
Yeah. So the easy answer is we have no data. But I'm not going to stick with the easy answer. I'm going to give you my opinion that's at least an educated opinion. And that is that while we know the virus can live on surfaces, under ideal circumstance, if you take a virus right out of cell culture and put it on a hard surface and come back, you can find it there, in some cases a couple days later. That's ideal circumstances. I think what I'm doing in my own home is washing surfaces with soap and water, so washing things down. I'm not going crazy with bleach. I'd rather not ingest bleach, and doing a lot of hand washing. So when I go to the grocery store, I wear a mask. I find grocery stores are really terrific about hand hygiene and making sure that our hands are well washed when we go in and when we're touching the carts. Some people are wearing gloves. I'm choosing not to do that myself, but it's a reasonable thing to do. Taking things off the shelf. The other thing I would mention is minimize the number of times you need to go to the grocery store. This is all about minimizing your risk of exposure. So the less you're out and about, the better. Better to save up your grocery shopping and go once a week rather than 2 or 3 times a week if you can. Then when you put your groceries in the car, you can then remove your gloves. I have gel right in my pocket that I'm using. When I come home, I take the groceries out, and I'm not wiping everything down myself, I will have to say. I'm just putting things away and then washing my hands carefully again. So I wash my hands as soon as I get home, soap and water for 20 seconds, put the groceries away, wash my hands again. When it comes to fresh fruit and vegetables, I'm just washing them with water and then letting them sit. We think that materials like cloth or mail that you get, et cetera, that the virus doesn't live on there for more than a few hours. And again, even if it's there, it's not likely to be with a very high amount. So you're trying to minimize your risk of exposure, and you're trying to minimize the volume of exposure. And so that was kind of a long answer, but Patrick, did that answer it well enough, or did I miss something?
That's great. No, there's a lot of detail in there. I think that people will find that very informative. Thank you. Here's a question that's a little specific, but I'm sure it's on a number of people's minds, and it's what pregnancy complications might exist with COVID-19?
Yeah, I've just been looking this up, and so again, very limited data. We had some concerns initially because everybody knows about the Zika virus and in the problems that was causing. Doesn't seem to be the case here. And we're looking now at different trimesters. It's almost, unfortunately, a natural experiment that's occurring. And we're trying to get, the problem is we want to get good, not just data, but good, valid, reliable data, particularly out of Italy and China, and to a certain extent, New York. But right now, I'm not aware of a direct connection between the virus and problems related to pregnancy. Nevertheless, just out of an abundance of caution, we've suggested that our pregnant healthcare providers aren't coming in and having direct contact with our patients, just because we just don't feel the risk is worth it. Women are allowed to make their own choice. So if they read the, especially our physicians read the literature, as some are, and saying, I just don't think it's that significant a risk, then they're allowed to come in. Most are choosing not to. The other thing I would just say is, there's also kind of the indirect risk, which is if you are infected with COVID-19, even if it's not a direct risk to the baby, if it makes you feel miserable and you're particularly getting close to delivery, theoretically it could trigger a premature labor or contraction just because your whole body is not feeling well. So these are the kinds of things we don't know, but the kinds of things that go through my head when I hear this sort of a question.
Great, thank you for that. And a couple of questions have asked about the susceptibility of different parts of the population, and are there any differences along ethnic lines or gender lines, or around blood type that make someone more or less susceptible to COVID-19?
The blood, I don't know the answer to the blood type question. That's something I can look up and get back to you on. Men do seem to be disproportionately affected compared to women. And related to racial ethnic issues, we're finding that people who are African American or Asian have higher death rates, proportionally higher death rates compared to white and Hispanic. Actually, white, it's about equal proportion in terms of how many people are COVID-19 positive and how many die from it. In the Hispanic community, actually, we're finding a lower death rate for people who have a COVID-19. And in Asian and African American communities, we're finding higher death rates. And we're launching studies to try and get a better handle on why that's the case and what we could do to help our neighbors so that that is no longer the case.
Thank you. And somebody has asked the question about the effect COVID-19 has on one's cognition, and do you know anything about that impact? Perhaps you could talk a little bit about that if you do.
Yeah, I know very little bit about it because the main work that's been done related to cognition is in these people who become very, very ill. And so whether it's directly related to COVID-19 or the fact that you were really ill and on a ventilator and getting a lot of medications, whether it's more related to that in terms of the cognitive changes, I don't know the answer to that yet, but we're certainly seeing that. The other thing we're seeing is that because many of the people who become very ill with COVID-19 are over the age of 80, where there's also a much higher rate of dementing illnesses or just cognitive changes, it's a little bit hard to tease that out right now.
Right, I see, thank you. Another question relates to asymptomatic individuals. Do we know why there is a high percentage of such individuals?
It's not clear. We don't know how much of this relates to your innate immune system, and that is absolutely an area of study. So we're really interested in studying people who are COVID-19 positive and don't have any symptoms. Now remember, some of those people will develop symptoms in the next days or week or so, but some will just sail through and not develop any symptoms at all. And we're very interested in what is different about their immune systems beyond just age and gender.
Laura, do you have information on why there seems to be such a high transmission from asymptomatic cases? I remember early on there was a lot of skepticism that asymptomatic cases could be transmitting. Now it seems there's a lot of evidence for it. Is that particularly unusual with this?
Well, no, I mean, it can also happen to us with other illnesses like the flu. So that also can happen. This COVID-19 though seems to be more easily transmittable than something like a flu virus. And so it just seems to be, and we don't know why yet. We don't know what about it. It just really is able to get to these ACE2 receptors. There's other receptors that it can get to as well. But it's just, it's probably some dumb luck, evolutionary luck, that it just happens to have the right fit for, if you think of it kind of as a lock and a key for these existing locks. It just by dumb luck has the right key to latch onto these receptors and create problems. And then, as I said, it just becomes, it converts our cells into these manufacturers of more virus that then gets shed.
Thank you, Dr. Mosqueda. I think we have time for probably one more question, maybe two, depending on how complicated the answer is. This is actually one from me, and as you know, my personal academic interests are in how people employee well-being in the workplace. And I wanted to ask about you and the staff at Keck, who I know are fighting COVID-19 on the front lines at LA County. How are people getting on? How are people coping?
Well, people are doing well. Yeah, I mean, we staff both the county hospital and our own Keck Hospital and Verdugo Hills Hospital, and of course our Norris Comprehensive Cancer Hospital as well. People are doing well. I think that I was on the phone this weekend with the head of our pulmonary critical care division, and she has a pretty exhausted team of people. And there's the impact of caring for so many people who are so ill. The impact of having, a higher number than usual of people die, the impact of families not being able to visit them, and our hearts go out to our patients and our families. And then the worry for themselves, that they're being exposed, that they could end up themselves getting COVID-19. They're worried about then going home and exposing their families to it. USC has been really wonderful in offering our healthcare workers quarantine places to stay in our USC hotel and other places, so that if you're worried that you've been exposed and you need to self-quarantine, or if you're just worried about exposing your family, that USC is providing them with a place to stay, and we're very grateful for that.
Oh, great, thank you. I think we're almost out of time here now, so thank you to all the people who asked lots more questions in the Q&A. I'm sorry we couldn't get to all of them. I'll personally say thank you very much again, Dr. Mosqueda, for spending your time with us, and I'll pass over to Gareth for some closing remarks.
Yeah, I'd just like to add my own thanks for a wonderful presentation and answering as many questions as you had time for, and clearly there's a great deal of interest in this topic. And thank you again for taking time out of your busy schedule to help us out.
Well, I appreciate it, and look forward to seeing some of you who I already know in person again, and to meeting some of you in person. So thanks very much for this opportunity.